Okay, good afternoon, everyone, and thank you so much for joining us today. My name is Elena Kussler. I'm the program director here at the Parkinson Association, and I'll be helping to facilitate today's presentation by Dr. Luisa Solis-Cohen, who's here to talk about all things medications and treatments. So we are really excited to have her here again. This is, I think, the third time you've presented for us, and it's always such a wonderful presentation. We're really excited to have you back. So before we dive in, I've got a couple of housekeeping items for you all. So first, the presentation will take the full 2 hours that we are here today, but we will have a break, short break right there in the middle so we can get up and stretch and move our legs. And I'll kind of go over some of these logistics again towards the end. We will be holding a Q&A session at the very end of the presentation, so right around 5:30, 5:45. And there are a couple of different ways that you can ask the questions. The first, you should have a little questions tab on your GoToMeeting platform. If you go ahead and click on that, type your question in, those will be sent directly to me, and I'll hold on to those and pop back on to ask them directly. Or if you'd like to vocally ask your question, you can raise your hand. There should be a little raise your hand button that you can click, and we can unmute you and you can ask your question right then and there. This presentation will be recorded, so there is a recording going to be available in a follow-up email that will be sent around this time tomorrow, and we'll also make it available on our YouTube channel. In your control panel, there's also some handouts available, from anything from a general Parkinson's 101 packet to an exercise class list. We also have a flyer for the Aware and Care kit from the Parkinson's Foundation on there that you can download and have available. We also have a link in the follow-up email that'll take you directly to those. And last thing, there is a survey after the presentation. It shouldn't take more than a couple minutes. Go ahead and take some time, fill that out. It helps us develop our programming for the future. A couple of upcoming webinars that we have in the future. We have a few coming up in June and at the beginning of July. All of these can be found at www.parkinsonrockies.org/educational seminars, and you should be able to register on there as well. In addition, our Vitality Walk is coming up on June 6th. If you haven't participated in the Vitality Walk before, it's a great way to meet new people and just kind of get the sense of, community. And if you want, go ahead to parkinsonrockies.org/vitality to register for that. And without that, well, this is our flyer for today. Just wanted to point out that our last session will be on June 15th, so be sure to tune in for that. That's all for me for now, and so I'm going to transfer over power, and we can dive right in.
Okay, thanks, Elena. Hi, everybody. I'm Dr. Solis-Cohen, Luisa Solis-Cohen. I'm a movement disorder neurologist in Littleton, Colorado. I am very clinical, so a lot of what I do is take care of folks with Parkinson's and other movement disorders. And part of the goals of my practice is to kind of make sure that people are very participatory in their care, that they really understand why choices are being made for them, and better yet, that they're making the decisions with the guidance of a medical doctor. Let me see, my view here is a little bit different. I want to see, bear with me for 1 second. There we go. Okay. So the title of our talk is The Ins and Outs of Parkinson's Treatments, and we're going to focus on medications primarily, but we'll talk about some of the other forms of treatments at the end. So things like deep brain stimulation and pumps and ultrasounds, we'll talk about those more briefly later on. And the goal of today is to familiarize folks with what these things are all about, how they incorporate themselves into what goes on in the body in Parkinson's disease, and how to kind of start a conversation with your doctor about some of these treatments. If there are any questions as we move forward, please feel free to reach out to Elena, and I think there's a little chat box here, and we can kind of stop and gear towards questions as they come about. Let's see. All right. So just a little slide to tell you what you're in for today. We're going to talk about Parkinson's disease, what we call pathophysiology, which is basically how in an anatomical sense and in a cellular sense, we have problems that lead us to Parkinson's disease, and knowing what those cellular and chemical changes are and how our medications are derived from what actually goes wrong. So to understand what's going wrong and how the medications that we have and the treatments that we have can help in that process. That's a lot. So after we talk for about 45 or 15 minutes, we'll go ahead and take a break. At that point, if there's any questions, feel free to reach out again, and I may answer some questions over the break, or we may just reconvene in a few minutes time afterwards. After resetting, we'll talk about motor fluctuations and advanced therapeutics, and that's something that's very commonly talked about in clinic visits with your neurologist, and then we'll talk about medications and treatments that are up and coming. So when we talk about what is underlying the problem in Parkinson's, a lot of people start with the discussion of, well, where in the brain is it? And it used to be that we thought we could kind of pinpoint where in the brain it is, but as time has gone on, we realize it's more than just one spot in the brain. We realize that this is actually a multifocal neurologic process that happens over time. And it happens in how cells and what we call neurons, or the cells in the brain, communicate with each other. So what I'm going to try to transition your thinking from is, instead of thinking as about the brain as a blob in the head where there's different lobes that do different things, and the former thinking of, oh, in the middle of the brain where we have these structures, some of which you may be familiar with, such as the substantia nigra, instead of blaming it so much on these things in the brain, what we want to kind of wrap our heads around is that actually in Parkinson's and in general brain functioning, we have this interconnected network of cells that, instead of just being confined to one region of the brain, they're stretching from short regions to long regions to help us do voluntary motor and involuntary motor, cognitive pieces of function, as well as other forms that are just really important in day-to-day functioning. And what I want you to focus on is how these cells talk to each other, because therein lies the crux of the conversation today. So there's about 100 billion brain cells, and we call them neurons. 100 billion neurons, that's a whole lot. And for each brain cell, there's about 10 to 50 supportive cells that we call glial cells. And you can imagine, instead of it just being a jumble of mess, it's actually a very neatly constructed system. And one cell has to talk to another cell in a coordinated fashion without misfiring, or without talking to a cell that it doesn't want to talk to necessarily. So we kind of see this dense network of cells with a cell body, which is that center little blob here. Oh yeah, I forgot I can use the mouse. So here's the cell body, and here's its arm projection going down to another cell that's off this page, and another arm projection going down to connect with the arm projection from the neighboring cell. And it's this little junction, which is in orange, there's multiple ones on this page, they talk. And sometimes they talk by electrical signals, but more often they talk by chemical signals. And see here. Every time I touch this, something else blows up at me. Okay, so the latest box that just came up was one arm projection of one cell talking to the other one downstream. And this little light here, this yellow greenish light, denotes some special occurrence that allows one cell to talk to the next. And in this case, it's the release of a chemical. Now this area, this what we call a synapse, or the space between the two cells, is very, 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 very small. It's even smaller than if you took a piece of paper and kind of stand it on edge. It's much, 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 much smaller than even that. So these two projections are so tightly knit, but they need a chemical to cross that gap and latch on to the next cell. And the reason that I'm telling you about all of this is because in Parkinson's, you may have heard that the crux of the problem stems around one chemical in particular called dopamine. So dopamine is a neurochemical. Basically, it's a chemical that the brain uses to have one cell talk to the next cell. And here what we see is we have a neuron, a cell body, where all of the infrastructure happens for the cell to make its proteins and chemicals and do its work. It basically generates signal all the way to its little feet projections down here, releases a chemical when it wants to fire the downstream cell. And that cell understands dopamine as the reason that it should activate and then generate a signal down to the next cell, okay? Over here on the right side, we call these dopaminergic neurons. We basically name them by the chemical that they produce to trigger the downstream cell. So this, and this is a blow up of if one of these foot projections here was connected to one downstream, if that makes sense. So what we have here is packages of dopamine at the ending of this cell. And those packages are released into this synapse space. And the dopamine actually will travel across and latch on to this receptor here. And by doing so, it triggers the downstream cell. Now, the hallmark of Parkinson's, the main problem, though not the whole story by any means, and the more we learn, the more we realize that there are many other facets to consider, but the hallmark is this dopamine deficit. So you may have heard this from your doctors or reading or wherever, and it's something to focus on. Over here off to the right, dopamine levels in the brain cells are reduced. So there's less dopamine to travel across that gap right here to trigger the next cell. This whole process is required for normal fluid movements. If the dopamine levels are low, that cell will either get erratic messages or it just won't get enough message. And then there'll be slowness or stiffness or sometimes an interrupted message like what may come about from a tremor. Now, okay, we understand dopamine is reduced in the brain cells in Parkinson's. Well, why, right? Why would it make less dopamine? We really have to understand why to be able to try to fix it, right? Or even prevent it from happening. So what we've learned over time is that the reason the dopamine neurons are not producing enough dopamine is because they're actually dealing with what we call a little bit of a garbage problem. So they're dealing with a protein that has accumulated in their cell. And that protein, also known as alpha-synuclein, is no longer allowing proper manufacturing, proper packaging, proper release of dopamine. And this picture off here that I'm kind of hovering over, this is actually a cell body, a dopamine cell. So this is the middle, that kind of circled portion. And here's one little projection. The other little projection is over here. Those are those foot processes that allow one cell to connect to the other cell. but the brown little bits are misfolded alpha-synuclein. And this is in a person who has Parkinson's disease. This is in basically a slide from the brain. Now, these bodies, when these brown little bits form a conglomeration, it's called something called a Lewy body. And there are actually Lewy bodies in Parkinson's disease, just as there's Lewy bodies in Lewy body disease, Lewy body dementia, you may have heard of it. And that's a little bit more of a complicated discussion of why having the same abnormality causes two different disease processes, but it depends on where they accumulate in the brain, is the easy answer. Okay, so the middle cartoon shows us what typically, if you're kind of Googling, well, what happens in the brain in Parkinson's, this is usually what will pop up. And basically up top in that middle portion here is a region of the brain called the substantia nigra, region in the middle. And this is one of those major dopamine producing areas of the brain. And it just so happens to be black. So the neuroanatomists had called it black stuff, so substantia nigra. And that's where its name came from. In brains of folks who have Parkinson's, this area of the brain, this black stuff, is less. So this whole problem of producing less dopamine is something that you can actually see in the brains of individuals with Parkinson's. Now, does this show up on MRI is something that we're always asked, and the answer is generally speaking, no. MRIs of the brain generally look normal and reassuring. If we have more advanced MRIs in the future, like instead of having what we call 3 Ts or 1.5 Ts, we have like an 8T in the future, maybe we'll see it, but we just can't see it right now. If you then ask, well, why is my neurologist even ordering an MRI of the brain? They're basically trying to make sure that the brain structure does look good and this is not a Parkinson's mimic condition. All right. So if we know the problem in Parkinson's, or a major part of the problem is this dopamine signaling condition, well, then if we just sit and scratch our heads for long enough, can we come up with some pretty good solutions for it? And that's a reasonable approach. So if you kind of think, well, how can I increase cell-to-cell signaling? How can I bypass dopamine loss? Can I just give more dopamine? Can I give something that's maybe a precursor to dopamine? Can I prevent the breakdown of dopamine? Can I act on the dopamine receptor? How about I just ignore dopamine and trigger that second cell? Will that work? These are all kind of strategies that were tried or are actually FDA approved. So it's worth going through that thought process, and that's what we're going to do. The first one, can we give dopamine? Well, that was tried in the 1900s, but the problem is when you give dopamine to a person, it's very unpleasant. So dopamine, if it's taken into the bloodstream, will actually cause flushing or lightheadedness or diarrhea, vomiting. It's just not well tolerated. And it does a lot of things to blood vessels and to the gut that just really make it not tolerable. So the first bullet point there is not really an option because of the side effects that produces. So our conversation is going to start with bullet point number 2 of levodopa. And I apologize for how complicated this looks, but we're going to come back to this slide periodically as we introduce the next thought in how medications work, okay? I'm going to focus your attention here. Here's where we're starting, levodopa substitution. So this is the first cell, and the signal is trying to cross this synapse gap to stimulate the second cell so that we have good normal fluid movement, okay? So basically one cell down here wants to talk to the next cell and tell it to fire. Now this is a glial cell, this is a supportive cell, and this helps modulate how much dopamine is present or not present in this synapse. Okay, So what we're going to do is talk about how can we make this first cell create more dopamine. And what we can't do is we can't just chew dopamine and push more dopamine to that system because it causes so many side effects. So instead, a precursor to dopamine is something called L-DOPA. We call it levodopa. And if we are able to give the body levodopa without causing a whole lot of side effects, well, then we can kind of shift this whole paradigm to the right, and we can help create more dopamine, even though it may be challenging, and we can stimulate that second cell. And so this is the area that we're going to talk about now. So carbidopa-levodopa, it's probably the most talked about medication in the Parkinson's world. Some people call it the gold standard treatment. Some people call it my dopamine supplement. Basically, it's something that we have been using in clinical practice since 1968, so a long time. And levodopa is a fairly natural substance because it's an amino acid. Amino acids, when combined, make up protein. So, so a generally naturally occurring thing. Because it's an amino acid, it actually gets absorbed with the other amino acids that we eat when we eat meals in the small intestine. And so you take that little pill, it's usually yellow. It goes into your stomach and into your small intestine. Then it gets absorbed into the blood. And from the blood, it has to go all the way up to the brain and cross what we call the blood-brain barrier. So the brain and the structure of our neuroanatomical system is pretty clever because it sort of anticipated the sense that our bodies would be exposed to toxic chemicals at some point along the way. And we should probably protect the brain. So we basically have at least 3 coverings around our brain that are very tightly woven, and they protect us from a lot of toxic substances. Now, fortunately, that helps us if you were to, drink or eat something that you shouldn't, and you don't want to go to your brain. But the problem comes about with medications that do need to go to the brain because they have to cross this barrier. So the fortunate thing is that levodopa can actually cross that blood-brain barrier, and it can do so and then get to the brain cells that it needs to. Once it gets to the brain cells, the body recognizes it as a natural substance and will convert it to dopamine via this AAD enzyme. So no big deal, you've got more dopamine. Now, when we prescribe dopamine in the neurology world, in the Parkinson's world, we always have this sort of start low, go slow paradigm. And this is generally a 3 times a day medication to start with. It can be much more frequent than that and at much higher doses than that. But what we want to do is make sure that folks tolerate this medicine at the onset, because there can be problems. If dopamine is broken down, if levodopa is converted to dopamine in the gut instead of going up to the brain before it gets converted, then there can be side effects, just like the side effects for people who take dopamine. So nausea, vomiting, lightheadedness, low blood pressure, confusion are some side effects that can occur because of use of this medicine. Hallucinations can happen, not as common as the ones before it, but they can happen. Dyskinesia is a word that we'll come back to, but a dyskinesia basically refers to an abnormal movement that is actually not a tremor. It sort of looks like a dancing-like movement, so a twisting of the neck or of the hand or of the trunk. If you've seen Michael J. Fox have recent interviews, he looks like he may have trouble sitting still, and those are actually dyskinesias. Carbidopa-levodopa is not the sole cause of dyskinesias. It's the magic duo of Parkinson's plus the levodopa, if that makes sense. Now, you'll always see that we have these two words together. Carbidopa is always with levodopa, and the reason is to help minimize the side effects that would occur if a person took levodopa alone. So the carbidopa basically blocks the potential of the levodopa to get converted in the gut and in the bloodstream instead of in the brain where it should get converted to dopamine, okay? There are several different formulations of this medicine, and they'll usually say milligrams/milligrams to denote the carbidopa/the levodopa. And ideally, it's a 1:4 ratio. So there's a 25-100 pill. That's great. There's a 10/100 pill. That's not great because the potential risk for side effects is greater there. There's less carbidopa than you should have. There's also a 25-250 pill, and again, not the best ratio. So we're really sticking with the 25-100 pill. That is just for the immediate release. There are also extended release formulations, and those are generally just designed into a 1:4 relationship. All right. Oh, here we go. Levodopa formulations. So this is our gold standard. So we're going to have many different types of it because we just can't get enough of it. Basically, it works for some people really well. Carbidopa, levodopa, immediate release acts quite quickly. Controlled release takes a little bit longer to act and then lasts a little bit longer in the system. Carbidopa, levodopa, ER is also known as Rytari. That is a capsule with little beads inside, and that has a really nice extended release formulation. Carbidopa, levodopa, ODT, orally disintegrating tablet, is for folks who may have swallowing problems or restrictions related to surgery about swallowing. It doesn't actually take a quicker time to onset, meaning it doesn't act sooner. It still actually has to go all the way down to the small intestine, but it allows it to disintegrate in the mouth. Carbidopa, levodopa intestinal gel infusion is administered directly into the GI tract with a small little hole in the abdomen that has what looks like a feeding tube. It's not a feeding tube, it's a carbidopa levodopa tube, and this is called duopa. And then there is an inhaled levodopa, which basically allows for an inhalation of levodopa. People have to be on their carbidopa levodopa at the same time, and this is designed to be a rescue medicine. We'll talk about rescue medicines later. All right, that's a lot. Let's see. I don't see any red flags, so we'll keep going. All right. Okay, so a very common question that we see when we're talking about carbidopa levodopa is to eat or not to eat with my levodopa. What do I do? So when people are starting out, my general recommendation is just tolerate the medicine. So do whatever it takes to make sure that you don't feel queasy and you're not lightheaded. So if that means you're eating it with a meal, go ahead. That's my personal 2 cents, quite honestly. The medical kind of textbook and the pharmacodynamics from the medicine say avoid protein 30 minutes before your meds and 60 minutes after your meds, because if you take it with a protein meal, your levodopa is going to have to compete with the breakdown products from protein meals in getting absorbed. So you may be absorbing less of the levodopa if you take it with a protein meal than if you were to take it on an empty stomach. And so early on in a person's treatment course, it may not matter if they have 100% absorption versus 50% absorption. But later on, if a person is requiring that their medicines be delivered exactly at a certain time without variabilities of meals, then they really will follow this strictly into the T. The important thing is to maintain nutritional status, of course. And so kind of really focusing on this as the primary concern rather than a more well-rounded approach can be somewhat detrimental at times. So really have a good discussion with your doctor about, does this apply to me? How much do I have to follow it? What are the repercussions? So levodopa has a lot of baggage and a lot of common misconceptions, and that's because you can imagine over more than 50 years of using carbidopa-levodopa, our understanding of what it does for us and how it's used in our body has changed. And the more that research has allowed us to understand what levodopa does, the more we actually advocate for early treatment with levodopa. Some of the concerns that I hear about directly are that I really am concerned about using levodopa early on and that it'll stop working in a few years. I am avoiding levodopa so I will not get dyskinesias. I'm scared levodopa will cause progression of my disease. If I take levodopa, I will develop a tolerance in the future, and I shouldn't waste my treatment on my mild symptoms. And the fortunate thing is that these are actually not true. So at one point in time, you may have read either variations of this in what we thought to be true as Parkinson's disease docs, but now we understand that early levodopa use is actually quite beneficial and significantly impacts quality of life early on. I'm going to kind of try to explain to you why. It's a little bit complicated in discussing, so if you lose me, it's okay. But what we've got here, and I've tried to simplify this chart because it was a little bit more complicated. Okay, so on the y-axis, we have dopamine neurons, okay? Percent of dopamine neurons, so 100% should be what you have. And then over on the x-axis, we have time, okay, for an individual. This represents an individual who has Parkinson's disease. Early on, they have 100% of their dopamine neurons. And as time goes on, this dopamine neuron population declines. And they may have onset of non-motor symptoms being loss of sense of smell, constipation, vivid dreaming, or other sorts of things. And over time, the dopamine neurons decline in terms of their population. At a certain point, motor symptoms start. And motor symptoms may not start until more than 50% of the dopamine neurons are lost. In the purple part of this chart, off to the right, this is after the person has been diagnosed with Parkinson's disease. And they may start treatment. They may start carbidopa-levodopa, or other treatments for that matter. And they may have a really great response to medicine. The objective of medical management at that time is to fill the bucket, to fill that dopamine deficit. So for example, if we're over here and we start medicine, we have to replace more than 60% of dopamine, okay? That's what we have to replace. As the disease marches on, the dopamine deficit increases and we have to replace more to have good motor function, okay? And as time goes on, we have to replace more, again, to have good motor function. This explains why levodopa may seem less effective for some individual as time goes on. The dopamine deficit over time increases, and it is not that levodopa becomes less effective. As folks may require more medicine over time, they may run into side effects that prohibit increase of medicine. And so when we go back, the bullet point number 1 is it will stop working after a few years. That's actually not true. It's just the dopamine deficit has gotten larger and more difficult to fill. And it's not that there is a tolerance in the future. It's just we require more to fill that dopamine deficit. And you shouldn't waste your treatment on mild symptoms. Well, I beg to differ, and so does research, because quite honestly, there's really good outcomes in this early pocket over here. People start trying treatment options when the deficit is larger. It's often harder to get good outcomes. A study that we turn to is one from the New England Journal of Medicine, and this is not the first one. It's not the greatest one. It's just one of the more recent ones from 2019, looking at folks with Parkinson's disease and then either giving them carbidopa, levodopa versus delaying it. And the conclusions were quite compelling. Early levodopa use did not impact how early dyskinesias started. So some folks fear the onset of dyskinesia so much that they don't want to start levodopa. And that's something that we actually used to counsel patients not to do. When this was studied, turns out that this is not the case. Dyskinesias start more dependent on the disease process than on when levodopa is incorporated in treatment. Early levodopa did not impact how soon or how severe motor fluctuations were, meaning when people have ons and offs, how early that was likely to start. We'll talk about that later. And then early levodopa did not impact disease progression, either negatively or positively. Okay, that's the carbidopa-levodopa story. That's probably one of the more important stories that's on our confusing slide here. Let's see, where are we going next? Okay, we're going to the dopamine agonist. Now, the thought process here is instead of giving the precursor to dopamine, what we're going to do is give something that the body thinks is dopamine, but it's not. It's just landing on the receptor and basically unlocking the key to trigger the downstream cell. Dopamine agonist formulations. So there are 4 basic ones. The last one, Apokyn injection, is actually a rescue medicine. We'll come back to it later. But the top 3 are regular interval medications: pramipexole or Mirapex, ropinirole or Requip, rotigotine or Nupro, which is a patch. And these may seem somewhat familiar because they're also used to treat restless legs. So dopamine agonists, like we said, they act on the dopamine receptor. It kind of tricks the body into thinking we have more dopamine, but lo and behold, we don't. Pill or patch, 1 to 3 times a day. There's a lot of really nice extended release formulations in this class of medicine. And these can actually be taken alone or in conjunction with other Parkinson's meds. Side effect profile is pretty significant to talk about. It's not that these will happen. It's just important to know what the side effects are that are associated with this class of medicine, to be on the lookout. If they were present, stop the medicine and they would go away. But very importantly, this can cause sleepiness, and sleepiness that comes in waves. So some people have a wave of sleepiness, and that's fine, they can stop the medicine, but it would not be fine if they were out driving and they suddenly had a wave of sleepiness and they drove through it. So we really counsel people, if there's at all any sleepiness with this medicine, it may not go well for you. Interestingly enough, it can cause insomnia at night. Can also cause confusion and hallucinations. So for folks who have cognitive problems, for folks who are a little bit older, I would even say 75 and above, we're a little leery about starting a dopamine agonist. We'll probably keep one if it was already started, but we're not gonna be starting high doses of that. Impulse control disorders. So that is inherent in Parkinson's disease itself, but also can be further exacerbated by Parkinson's disease medicines, including your dopamine agonist here. Impulse control disorders refers to the tendency to have pretty strong compulsions for things that a person may not have had before, and it happens in a socially unacceptable fashion. So predilections to wanting to eat a lot, binge eat, or to pornography, or to rearranging things. It can be pretty disruptive. Gambling is another one. And again, bring up these side effects because they can happen. Some of them happen because of the Parkinson's itself, and some of it's more clearly a medication effect. That has to be discussed exclusively with physicians to kind of understand what's what. All right, so how do your medications work? Back to this slide again. We're going to talk about this bottom part here. This, what we see is an MAO-B inhibitor and a COMT inhibitor. But basically it boils down, these are enzymes that break down the dopamine. They're like little Pac-Man that control the amount of dopamine that's in that synapse to make sure that the second cell doesn't fire erratically or too strongly. Oh, let me go back to it. So the thought here is if we block those inhibitors, then we can allow more dopamine to hang out in that synapse and allow that second cell to be triggered. So if we can't make enough of the dopamine that we need, well, if we just stop the breakdown of it, we'll kind of trick that second cell into thinking we have more than we do to allow that pathway to continue. So MAO-B inhibitors, there are 3 of them that we use regularly. Most people are familiar with rasagiline, that middle one, also known as Azilect. It's been around since about 2007, I think. Selegiline is one that's a little bit less frequently used. Sulfinamide is also known as Xadago, and that's the one that has to be used with other Parkinson's meds. The first 2 can be used actually as monotherapy, which means like to be used alone. Again, this prevents breakdown of dopamine in the brain, once or twice daily dosing, depending on the form. Side effects are listed here. The biggest one to be concerned about is the blood pressure fluctuations. So can cause lows, but can also cause episodes of severe high blood pressure. That's more if a person takes something with it that they shouldn't. I tell all my folks who are on MAO-B inhibitors to have a little printout of the things that they shouldn't be taking while they're on an MAO-B inhibitor. So there are over-the-counters and there are supplements and there are prescription medicines that if you take with an MAO-B inhibitor, it can cause pretty profound high blood pressure, and that can be dangerous. So it's important if you're on this class of medicine to know about it. The things to avoid are written there. Tramadol is a pain medicine, Robitussin, DM. The DM is the part that we don't want. It's the dextromethorphan. Methadone, St. John's wort, and there are others. You can ask your neurologist for a list of the things that if you're on an MAO-B, you shouldn't be taking. You can also just go up to the pharmacist and I say just like advertise the fact that you're on this medicine, and they can just run a interactions check for you. We used to say avoid tyramine containing things. We called it the cheese effect or the red wine effect. Basically, if you took that in conjunction with this class of medicine, we used to think that caused higher blood pressures. We have since debunked that. So you can drink red wine and eat aged cheese now. I don't know about the animal liver as being so palatable to begin with. Let's see, antidepressant interactions are very real and somewhat limit use of this medicine. Okay, COMT inhibitor. Again, this is another medicine that we have that allows more dopamine to be seen in the brain. And it does it a little bit differently than the inhibitor that we just talked about. It actually allows more levodopa to cross the blood-brain barrier and inactivates the enzyme that would break it down in the blood. Regardless of how it works, it basically allows more dopamine to be transferred from one cell to the next cell. And there's two forms that we use. Entacapone we've been using for years. There used to be a combo pill. You can still get it, but it's not as readily used with carbidopa, levodopa, and entacapone. But that entacapone is basically like an extender, and it has to be taken with each levodopa dose. If you take it alone, it doesn't do much. In 2020, during the pandemic, there has been release of a new form of a COMT inhibitor, and this one's actually extended release. So this is a once daily form called opicapone, and that's another treatment option. So side effects are listed here. The orange-brown urine mostly applies for the first formulation, the entacapone. It's not concerning or dangerous, it just has to do with the metabolite. All right, we're doing pretty good. We're getting close to our break, I'll tell you. So if you've noticed, I've had to add in a little symbol here, a little receptor that wasn't on the prior slides. But basically, the next drug that we're going to talk about acts on a unique receptor called the A2A receptor. And it basically then snuggles up with this dopamine receptor to trigger the downstream cell. So it uses a little bit of a unique mechanism of action, but at the end of the day facilitates transmission of the signal from these cells. And we have a relatively recent medicine with this mechanism. The medicine is called Neurodiagnosics. It acts via that A2A receptor, and it's actually a metabolite of caffeine. And the goal is, again, to indirectly this time stimulate that second dopamine neuron. And side effects are similar in keeping to the side effects that we had already discussed of the other medicines. All right, I think this is my last one, and then we'll have a break. An NMDA antagonist is typically a cell that puts the NMDA receptor typically puts a brake on the cell, the second cell. And if we antagonize that, we'll let that cell actually fire. This principle of a medication is something we know of as amantadine. Amantadine is actually an old influenza antiviral medicine. So it was thought to shorten the duration of the flu for folks who got the flu. And it was actually curious because some folks who would take it had some improvement of their Parkinson symptoms. So then it started to be used in Parkinson's disease for tremor first. Wasn't really that great for tremor reduction alone, but it does some. But more importantly, for reduction of those wiggly extra movements that we call dyskinesias. So over time, amantadine basically has been used in a sort of a grandfathering fashion of approval, and was used in an off-label fashion. Now, there's complex mechanisms of action. There's a little bit of a dopamine boost, but more so there's a reduction of another chemical we call glutamate. And that's either here nor there. But recently, the story with the amantadine sort of blew up. In the past, I think it's 3 or 4 years now, we have 2 extended release forms of this. You may have heard of them. Let me see if I put them on. Yeah, okay. So one of them is Gocovri, which you take at night, and the other one is called Osmolex, which you take in the morning. And they're single daily doses of the amantadine in an extended release fashion. And these allowed us to have some studies that looks at the efficacy of amantadine in dyskinesia suppression and reduction of Parkinson's symptoms. And so now it's actually FDA approved for those purposes. And the first one, amantadine IR, is generic, and that's typically dosed 2 or 3 times a day, versus the bottom 2 are once a day at the times that I list there. Let me see, I'm gonna go back to the prior slide. So side effect profile of this medicine, although it works nicely for folks that it helps, it can cause problems. Hallucinations is actually the biggest on the side effect profile list. And we, again, if a person is having cognitive impairment or any hint of a hallucination, we will avoid it. It can cause some lower leg swelling and also a lacy rash on your legs. If people have problems with their kidneys, we will usually dose lower to accommodate for that because this medicine is cleared by the kidneys. Oh yeah, trioxyphenidol is an old one, but a good one. We use this as a sort of additive medication for folks who have tremor and dystonia. It can have side effects that are prominent, especially as folks get older in life. Actually, kids can tolerate a lot of this medicine, and adults have a more difficult time, interestingly. The side effects are listed there. We generally turn to this when there's a lot of dystonia and Parkinson's. Dystonia is a posture that is generated by the brain. Instead of having a balance between action and relaxation of different body parts, there is an overaction that is manifested as either an arm kind of flexing into the body, or toes curling down, or a foot scooping in, or a neck tilted. All right, I think, let me just peek. Yeah, we're taking a break.
Okay, so we'll go ahead and take a break. Do we want to say about 5 minutes for a break?
Sounds good.
Awesome. So let's go ahead and meet back here around 4:58. Okay, so we're over with our break now. We can go ahead and move into the next section.
Alina, can you see me and hear me?
Yes.
Okay, perfect. All right, so okay, got it. Okay, so what we're going to talk about next is something that you may hear of as ons or offs. Are you on or off? Or how are your medications working? How often are you in the off state? How often are you in the on state? And these questions get kind of tricky because even folks who know what on and off are, it's hard to sometimes put yourself into a category. So what we're talking about here are motor fluctuations. Let's see. And that's this kind of roller coaster experience in terms of the motor state that one is in. So when we talk about on, what we're talking about is that we are getting relief of motor symptoms in Parkinson's, such as slowness, stiffness, and tremor. So our medicines are working and they're on. And that can happen typically somewhere between 20 and 40, or usually 30 to 50 minutes after a dose of medicine. And there may also be a state that a person is experiencing, such as their symptoms return. So the slowness, stiffness, and tremor may return after a period of having had improvement from the medicine. And so we call this an off state. Basically, I think that it's important to know some people have on and off states, and some people have on and off states later on, and some people actually never have on and off states. So to be very clear, if your doctor asks you, are you on or are you off, to say, I don't know what you're talking about. And then the next step in that conversation would be, okay, what are your Parkinson's symptoms? What are the symptoms that brought you to diagnosis? Okay, so it's a little bit of tremor in the right hand. Okay, so when you see that tremor come back after having a period of symptom relief, then you may be in an off state. If it still sounds sort of foreign, then you may not actually be experiencing offs and ons. or you may need to clarify it with your doctor. And this is where communication is very important. I'm going to kind of walk you through a couple scenarios. And it's important to know that on and off these states generally are seen with carbidopa-levodopa more than other dopamine-containing medicines, although it can be seen with other medicines too. So I'm going to walk you through this little diagram. Over here on the x-axis, we have the time of the day. So this is one single day in the life of, let's say, Joe, who has Parkinson's. And on the y-axis, we have motor function. And Joe may be in this off state down here where he has tremor in his right hand come back and his right foot lags when he walks. Or he may be in an on state where he has no tremor and his walking is actually pretty good. Or he may be in a state that's called on with dyskinesia up here. And that may be a little bit of a neck shimmy, a head bob right to left. That's hard for him to control. But he doesn't have tremor at that time, and he doesn't have the right leg lagging at that time. And so Joe actually takes a dose of his carbidopa-levodopa in the morning, and in his bloodstream there is an increase in the levodopa level, and there's a decrease in the levodopa level, and there's an increase in the levodopa level and a decrease with the next dose and then the following dose. But look at this, he stays within this blue bar. He stays within the well-controlled on state where he has no tremors and he has no lagging of his right leg. So lo and behold, if you ask Joe how often he has ons and offs, he has no idea what you're talking about because he's actually only on, he is only well-controlled, and his carbidopa-levodopa allows him to remain in that blue bar, okay? So let's talk about somebody else. This person will be Susan, okay? And it's a similar type of a graph, so you kind of know what we're gonna talk about here. Time of the day, different motor states, takes same thing, takes carbidopa-levodopa. But now Susan actually wakes up with having a lot of stiffness in that left leg. And she wakes up with stiffness in the left leg and a lot of slowness. She takes her carbidopa-levodopa, and then a few hours later, she's actually doing quite well. She goes out for her walk. But then she realizes that she has an involuntary movement on that left side. The left arm and the left leg may be wiggling, and that's on with dyskinesia. She doesn't have the stiffness anymore, but she sure has these dyskinesias. And then she falls back into a reasonable state where her Parkinson's slowness and stiffness is better. But then she goes into an off state where that slowness and stiffness comes back. She takes another dose and goes through that same roller coaster of being, okay, I'm fairly well treated. Oh no, I have these involuntary extra movements, these dyskinesia wiggling movements, and then goes through it again. So Susan's having a pretty rough time because she has 3 distinct motor states: the dyskinesia state, the on where her symptoms are reasonably well controlled, and then the off state where she has that stiffness and that slowness come back. And this is a person who's experiencing ons and offs. And you can imagine if you broke the day into hours, you'd be able to kind of say, okay, I've got all these different versions of my motor function at different times, and here are also my dosing times. Whereas Joe would not know at all what she's talking about. So this little section up here on with dyskinesias, I just wanted to clarify a little bit for you guys what this means. What are dyskinesias? Are dyskinesias tremors? When are they bothersome? Let's see if I can phone a friend. We're gonna skip this in a second. Okay. I don't know if you can hear me and the audio because I've never done this one on Zoom. I'm going to let you guys listen for a second. Lena, can you just let me know if you can hear this?
Yeah, I think you might have to turn up the volume on your computer. We might have muted earlier.
Is that better or no difference?
Ooh, I can't hear it.
Okay, it doesn't matter if you can hear it because the important part is the visual, as long as you can see it. So you've got Michael J. Fox, and he's demonstrating his dyskinesia. So he's in a on state with dyskinesias. He has accurate involuntary movements. The audience doesn't help me now. So you can see there's sort of a twisting fashion of his neck. But you can see that kind of wiggle. Michael J. Fox is very good at repurposing his dyskinesias because he sort of makes it into a purposeful thing with his arm across his leg to make it less socially apparent. But that little wiggle that's there is a demonstration of dyskinesia. That's pretty good too. Sometimes it's just affecting an arm or a leg. They're talking about how wonderful person. Anyway, enough of YouTube. Let's go back. Now you've got a little bit of a demo. Okay. And escape that. And go back here. Okay. So dyskinesias are that wiggly extra movement. It's important to really hone in with your neurologist about, okay, I have this movement that happens to me. I'm not sure what it is. Is it a tremor? Is it a dyskinesia? Is it something else? I often tell people video it. If it doesn't happen when I'm with you, video it and bring it back to me so we can classify it. If we misclassify something and you tell me it's a dyskinesia, but it's actually a tremor, then I'll actually mistreat you potentially. And when I could have helped you, I'm struggling. So I think it's important when there's movements that you either don't experience together in clinic or you're not sure to really hone in and put a definition on it so that you can get some pretty good care and objective treatment for whatever that movement is that may only happen at night instead of during the day. As you saw with Michael J. Fox, that dyskinesia was there, but most people aren't bothered by dyskinesias. Most people would rather be at an appropriately high level of medicine, and whether or not there's dyskinesias or not is sort of less bothersome than being in an off, slow, stiff, off state, okay? Dyskinesias, they don't happen to everybody. Dyskinesias do require that there's a dopamine dysfunction in the brain. They also are seen with folks who are taking medicine. And there's this process of another chemical part of the equation called glutamate, and that being overactive. Okay, so if you need to talk with your neurologist about the different motor fluctuations that you have or the different symptoms that you're experiencing, the best thing to do is to keep a diary. There's a lot of really good diaries on the Parkinson Foundation, or your neurologist may have one that they like better. The VA actually puts out a pretty nice one too. Yeah, this is actually from parkinsons.va.gov, so you can get this one for yourself. And basically, they usually categorize the day in either hour slots or half an hour slots down the page here. And then for each time interval, you basically check a box. I'm either on with dyskinesias, off, or asleep. And you go through the day and you fill this out, and I would say it's good to do 3 days or so before you can come up with a trend. Sometimes this is way too complicated and people can't categorize themselves in a box, but they've got a problem symptom. So for example, somebody has freezing of gait, their foot stutters to the ground, and they want to capture whether or not there's a relationship to their medicine. So what they'll do is they'll cross off the on with dyskinesias, the off, and they'll just put freezing of gait. And whenever they have that, they'll check the box for me. And then we'll go through, okay, when did you take your medicines versus when did you have freezing of gait, or does this only happen at a certain time, so we can strategize an effective treatment plan. This is my motor diary, but I've actually since revised it. This is just one option of what it may look like to fill this sort of diary out. I like for people to put exactly the time that they took their meds, because sometimes, although you're supposed to take it at 11, you take it at 11:10 and no big deal. However, sometimes I have difficulty understanding that you may be off at that time because you were late on your medicine, and that's normal. People are late on their medicine sometimes. Okay. So as if it wasn't complicated enough, we have talked about off thus far as an early wearing off before the next dose. So you get a reasonable symptom improvement from that dose of medicine. It may wear off before you're due, and that's a kind of a type of off we call early wearing off. There may also be morning off, which is for some people more profound. Some people don't have morning offs actually, and that's a whole other explanation. But having morning off periods of slowness and stiffness and having a really hard time getting going in the morning, that requires a different sort of strategy and treatment. So make sure you kind of communicate these things with your physicians. The last one, the sudden unpredictable off, is really frustrating both for the individual and for their neurologist, because no matter what you do, you can't predict it in advance. So you have to come up with this sort of on-call strategy to suddenly turn a patient from a pretty profound off state to an on state, and that is challenging. In that sudden unpredictable off, oh, I'm not going to that discussion yet. I forgot about this slide. So what can we do about off time? Well, if you have off time that's kind of scattered throughout the day, you can either change the timing of your medicines, or you can increase the number of doses of medicine or increase the dose itself, switch to a longer duration action medication, add medications that either extend the duration of action or act downstream. The one thing we haven't talked about yet is this last strategy, which is a rescue medicine. Yeah, I was looking for this slide. So rescue medicines, we have 3. And when people have sudden unpredictable offs and they need to go from an off state to an on state rather quickly, and they can't wait for their medicines to take effect, we have 3 options. We've gotten 2 of those options in the past 3 years. So it's been a little bit of an explosion in the rescue medication region. Apokyn is our oldest one. This is an injectable apomorphine, which is not like morphine, the opioid, but this is a dopamine agonist medicine, okay? And Apokyn can cause nausea and flushing and lightheadedness. So often in the first month of using this medicine, people are pre-medicating with another medicine to ultimately be able to tolerate the injections. And they do work well, turning on in about 20 minutes. Kinmobi is it looks like a Listerine strip. So it's a little dissolvable strip that you put in your mouth to help people transition to an on state faster. And then the last one, Inbrija, is an inhaled levodopa that has to be taken in conjunction with some form of carbidopa levodopa. And this is so you puff it and you'll have an earlier onset of action. Problem with that one is some people do have coughs related and can't tolerate it. Okay, so we talked about offs. We talked about unpredictable offs, and now we're going to talk about how do we reduce dyskinesias. So again, the dyskinesias are those involuntary movements that most oftentimes say that your levodopa level's a little bit high. We can lower the levodopa dose. We can do longer intervals between the dosing, or we can just get rid of any extender or extended release that we have. The alternative approach is adding amantadine. And again, this is that old antiviral flu medicine that we've repurposed to treat dyskinesias. And adding amantadine is often effective if it's tolerated. So believe it or not, we talked about most, if not all, of the Parkinson's medications, and those are a lot to kind of listen to in such a short period of time, but at least you've kind of heard about them or know about some of our strategies and some of our options. And again, bring those to your doctors who know you well to discuss if they're right for you or kind of why you're on what you're on, and more clues about your motor fluctuations. So we'll turn for the next part of our discussion to what happens if that's not enough, or what are the options, even if that is enough. Deep brain stimulation is what we call an advanced therapy. And that doesn't mean that you have to have advanced disease and you fall in a certain stage of Parkinson's disease. It just is a treatment option that is not a medicine. It requires surgery. Duopa is another advanced treatment option. This is that intestinal gel infusion that does require you to have a tube into your GI system. So it looks like it's a small feeding tube and you carry a pump. And then the other option is high frequency ultrasound, which is a non-invasive approach, but there is changes to the brain tissue. We'll talk about that. So the first one, deep brain stimulation, is a FDA-approved technique for tremor since 1997. For Parkinson's disease, dystonia, and there are actually other non-Parkinson related FDA indications. This involves placement of a tiny electrode deep into the brain in the Parkinson's disease symptom generating regions and providing a low current electrical stimulation to those areas of the brain. That stimulation is generated from a battery pack. So the battery pack sits just below the collarbone. There is a wire that is under the skin that connects to a little skull cap here that's all under the skin. And the electrode sits within the brain, providing stimulation. Deep brain stimulation in Parkinson's disease is done for several reasons. It is done to help smooth out the motor fluctuations. So if people are really transitioning, like that person, Susan, we were talking about, when there were ons and offs that were multiple times throughout the day, despite best medical management, to smooth that kind of a roller coaster effect, deep brain stimulation is great for. If there is a person who has tremor despite best medical management, it's also helpful for that. To reduce dyskinesias, also very helpful for. To improve dystonia, so again, that's the foot curling, the foot scooping, or the arm kind of contracted in. When we talk about walking and expectations with deep brain stimulation, that's really a one-on-one kind of a discussion. There are certain gait patterns that improve with levodopa, but there are also times when I wouldn't expect deep brain stimulation to improve. The goal of deep brain stimulation is not to get rid of all your Parkinson's medicine. It may reduce the need for medications, sometimes even 50% or more, but the goal is for quality of life improvement and to consider maybe modest medication reductions. What's involved in the DBS process? I think any elective surgery should have a pretty annoying pre-surgical process. As just, this is the nuts and bolts of having an elective surgery. And I think it should be even more rigorous when it involves the brain. And so it is. To consider deep brain stimulation surgery, need the involvement of a neurologist, typically a movement disorder neurologist, to confirm the diagnosis, discuss expectations, do a on-off evaluation with Parkinson's medicines, review an MRI of the brain, review the neuropsychological evaluation that allows us to check cognitive performance and attention, and to have an evaluation by the neurosurgeon, who is the person that does the implantation and the battery placement. So that's stage 1 and 2. The lead is implanted either with a person awake or asleep with certain techniques. There's actually many different techniques these days. And then about a week or 2 later, the generators, which are the batteries, are placed under the skin. And that connective wire is basically connected from the skull cap under the skin to the battery. After about a month after surgery, one person would return to their neurologist for programming. So actually the system turns on only with the neurologist. And then there's several follow-up programming sessions. Sometimes it takes up to a year to find good lifelong settings. But as time goes on, this device needs to be constantly checked. And just like if a person has a pacemaker, they go in for checks of their system. A person who has DBS goes in for checks of their system and sometimes modification of their programming. When is the right time for DBS? So we used to call DBS an advanced therapy because we would use it in advanced Parkinson's disease when a person had symptoms on both sides of their body and they had trouble walking and they were declining. Now we like to advocate for deep brain stimulation when there are motor fluctuations, and actually much earlier, because the impact on quality of life, good quality of life years, are much better when DBS is done earlier. And so usually we will start considering deep brain stimulation after 4 years of symptoms in a person who has motor fluctuations or has symptoms that just don't really respond well to medicine. Having a good response to medicine or not a good response to medicine is kind of beyond the topic, the level of our discussion today, and it should be discussed on a one-to-one basis with your neurologist. It needs a person to have good overall health, a good support system, and really not a lot of trouble with swallowing, significant speaking difficulties that don't respond to medicine, or significant walking challenges. The reasons to avoid DBS surgery are kind of listed here, but that's the goal of that pre-surgical evaluation, to kind of figure out who's going to have a good outcome, who should do the surgery, and maybe who should consider other therapies. There's complications from every surgery, including deep brain stimulation. These include having bleeding in the brain or a stroke, having a lead that's off target, having confusion or cognitive difficulties after DBS, any infection, scalp erosion, breakage of a wire, speech difficulties, and falling. There's a lot of good literature about outcomes in DBS. They all come up with ranges of what the expectations are. So motor scores, we all do a systematic motor rating score as part of the pre-surgical process. And generally speaking, it's safe to say that motor improvements on those physician rating scores were 30 to 50% better. There was increased on time without dyskinesias, so that good middle bar that our patient Joe was experiencing, more time in that state, more than 4 hours a day, which is actually a significant change, and improved overall quality of life. That is a pretty variable range. So that was our first topic of conversation, the deep brain stimulation. We're switching gears now to Duopa. So levodopa intestinal gel infusion, FDA approved since 2015, but used in Europe for more than 10 years before that. This is basically allowing a gel form of carbidopa levodopa to be directly administered into the gut. So there is a little tube that goes directly into the stomach. The tip of the tube, you can kind of see it here. This is the stomach. This is snaking all the way through, and the tip goes into the small intestine. And if you remember from the beginning, that's where levodopa is absorbed. This allows people to have smoother motor fluctuations. It's eliminating any kind of disruption from the stomach, and it substitutes most oral medications. So it's good for people who need to take medications very frequently, and it's very disruptive in their life to do that, or meals really interrupt their absorption and they need a more consistent way of getting this medicine into them. Yeah, so this is the equipment. So this is the hardware of the pump, and then this is the cassette filled with that gel infusion. This B detaches from A, and B gets refrigerated. So it's 1 cartridge per day, but you have a whole lot of cartridges in the fridge. So each day you put a new one on. You wear it during the day, and then at night you disconnect over here, and you flush the tube, and you either take 1 dose of oral medication or nothing at night, and then you rehook the following morning. Pump and the cartridge can be worn in all sorts of different carrying devices. So they're either in a vest or in a fanny pack or different sorts of garments that people wear. And you can detach them for swimming or other sorts of things. So DBS versus Duopa. Just a couple points about how they're different. DBS is obviously brain surgery, and Duopa's GI surgery, which is considered minor. In terms of candidacy, for DBS, candidacy is very important. And if there's significant cognitive problems or significant falling, there's several disclaimers on that one that are individual. Swallowing dysfunction, maybe candidacy is not ideal there. For Duopa, there's sort of less contraindications. Even if a person has cognitive impairment, there may be a caregiver to hook them up to the pump. And so the biggest thing for the Duopa category is logistics of getting hooked and unhooked to the cartridges. For deep brain stimulation, it's really good to have social support, at least in the beginning, when a person has 2 back-to-back surgeries, needs to go for their initial programming. It's just good to have somebody there to support them through that process. High frequency ultrasound, this is a therapy that has been approved since 2018 for tremor dominant Parkinson's disease. That's a subtype of Parkinson's. It only treats one side of the body. So it's important to know that this is a one-side fix. So if you have tremor on both sides, the expectation is you would kind of pick one side to fix. So this technique is carried out in an MRI scanner where you have a very fancy cap like this person here, and the MRI is used to coordinate the part of the brain that we would like to focus these very high frequency beams of ultrasound to. Those beams essentially heat up an area of the brain that causes damage to a very small area of the brain, with the thought that that area is the tremor producing area, and destruction of it will lead to tremor resolution. This is a therapy that should be considered in consultation with your neurologist and with the neurosurgeon who performs it. It is not a reversible procedure. There is a one-time chance to basically use the focus ultrasound if you target an area that's too big or too small or too far to the right or too far to the left. You can have inadequate outcomes, or you can have side effects like numbness and tingling of a body part, or even weakness. All right, so we're up to our last little marker here, meds in the pipeline. The positive part of all of this is the amount of resources that are brought to the table by many different foundations and allow significant advancement in medications that are available. And I think it's really important to know, like, if you look at talks like this in terms of medications and treatment options that are available for people, these talks change as the years go by. We constantly are like updating, oh, the medicine wasn't even available 2 years ago, and the slides just kind of are increasingly more complicated because of the mechanisms of action that we have for treatment options. And the number of medications that are currently in phase 2 and phase 3 trials now are quite thrilling for us. I mean, we want to fix this, you know, as much as our patients. We're not living it, but we have a strong vested interest in getting people better. So this pipeline is always that really hopeful aspect of these types of talks, but also it's very real in Parkinson's and some other disease conditions. I feel like it's less tangible than it is here. So subcutaneous pumps should be coming soon. These are pumps that are delivering either carbidopa-levodopa or apomorphine, which is a dopamine agonist, directly under the skin and just under in the subcutaneous fat. So it is less invasive than Duopa because it's not a tube into the stomach. It's just under the skin. And it's pretty streamlined in terms of its device. So we're waiting for this. This is also something that's in phase 2/phase 3 trials, which is, remember that protein we talked about earlier, alpha-synuclein, which may misfold and then may cause Lewy bodies, which basically impede normal functioning of the dopamine neuron. So if the alpha-synuclein misfolds and causes this process, you know, we'll have dopamine cell loss. But what if we can target the misfolded protein and either get rid of it or prevent that from happening? And that's where we are in terms of generating antibody therapies against alpha-synuclein. Everybody always asks about CBD and Parkinson's disease, and of course we didn't talk about that today, but what we do know is that CBD is helpful for some folks who have pain. There's a lot of good literature about pain response, but in terms of motor benefits, we've got some data, but that's still ongoing. There's a little bit more data about some improvement of non-motor symptoms, but basically for now. Okay. Actually, I didn't talk about some of the other new ones. I'm missing slides, but there are other combo medication therapies that we're hoping are going to be helpful, as well as advances in deep brain stimulation therapy with new manufacturers and virtual programming that we're pretty excited about. Okay, so the FROX Trial Finder is just one way of being part of the Parkinson's research community. And I think that these are very impactful in changing the treatment options that we will see in the future. So you can kind of go here. You can also go to I think it's clinicalgov.org, clinicaltrials.org. It's motor memory for me. I have to type it. Okay. And that's where I'm going to leave you. If anybody has questions, I'm happy to answer. And thanks for listening.
Hey, thank you so much for that so thorough presentation. I always love listening to it. So I'll go over really quickly how you can ask some questions again. I already see we have a couple coming in, but if you go to your questions tab, you should be able to type your question in there, and I will ask that question to Dr. Solis-Cohen. Or if you've got the raise your hand button, you can actually click that and we'll unmute you and you can ask your question directly. So we'll start with this first question from Mindy, and her question came up when you were discussing levodopa and eating. And her question is, how much protein would affect the absorption of carbidopa-levodopa?
Ooh, that's a really good question. Theoretically, it's any, but I don't know the exact answer of like what is the threshold for you to notice a clinical change. I think it's going to be trial and error is going to be the most helpful answer. In my mind, even if a person has, let's say, a burger, for example, which has a significant amount of protein in it, it's not that you get no carbidopa levodopa absorbed, right? It's that you get a reduction, like a percent reduced. So when I like to think of that percent reduction as like maybe 30 or 40% reduced. So how many grams of protein versus what that percent changes to, I'm not so sure, but I think that's a good question.
Awesome. Okay, I see Joe has his hand raised. So Joe, I'm going to go ahead and unmute you, and you'll unmute yourself and you can ask your question directly.
Hi, thanks for the presentation today. So my wife has just started taking levodopa carbidopa, and she's had a really hard time tolerating it. She's taking it with breakfast. She's just taking one pill a day right now, and then we were having trouble with it. So then the neurologist said, "We'll just cut the pill in half," but we're still having nausea almost every day, and vomiting even at times as well. So just wondering what the best way is to move forward, and is it possible that she just can't tolerate this medication?
Yeah, so this is something that I see a fair amount. She's not alone, and you basically need to work harder with the neurologist to get something that she tolerates. So I would say the carbidopa levodopa should really always be started as a half a tab to begin with. If she can tolerate a half a tab twice a day, I would probably try to sit with that for now before whenever your follow-up is with your neurologist. I'm not supposed to be giving medical recommendations on an individual basis, but that's what I would do in this just like generic situation anyway. I would say that if there is still a lot of nausea, that sometimes we're either increasing the amount of carbidopa by adding carbidopa as a standalone, which can be expensive, or we're giving an anti-nausea medicine. And there are several anti-nausea medicines as options, but there's really only one anti-nausea medicine that we like in Parkinson's, which is Zofran. All the other all the other anti-nausea medicines can actually cause worsening of Parkinson's symptoms. So basically, if we can't do a half a tab twice a day for a longer period of time, maybe an anti-nausea medicine needs to be incorporated to tolerate this. The other option would be to go to an extended release form of carbidopa levodopa. Sometimes the peaks of the standard formulation, that yellow pill, sometimes the peaks are too high, and that's what causes the side effects. So if you go to a continued release or Rytari, for example, it sometimes is more tolerated than the form that it sounds like you guys are on. So I think there's a lot to do and a lot to try, and sometimes those effort works, and sometimes people still have nausea, which makes this medicine very difficult. But I would keep at it for now, and I hope that helps you.
Yeah, and is it a matter of like eating more or eating less to avoid the nausea, or?
No, so generally speaking, you know, a few crackers or a piece of bread, or, you know, just like a regular meal should be enough. Sometimes people find like drinking a lot of water with it helps, but I've also heard that it disturbs their stomach and causes the nausea. So I don't think it's the quantity of food. A little should be enough to help with queasiness if it is going to help.
Okay.
Awesome.
Oh, and do you know of any? Do you know of any negative interaction with thyroid medication? Because that's supposed to cause stomach problems too.
Yeah, no, it's just that thyroid medications need to be taken alone, but no, there's no interaction of Parkinson's carbidopa-levodopa with like levothyroxine, let's say.
And when you say alone, like a half an hour earlier, is that sufficient, or it should be longer?
Yeah, no, usually thyroid medicines are a half an hour on each side of the medicine of nothing in the system.
Okay.
Yeah.
All right.
Good
Thank
luck.
you.
Yeah.
Okay.
Thank you. Okay, so we have another question in from Paulette, and her question is, will you explain the need for the night dose of carbidopa-levodopa?
Yes. So depends on the symptoms that you have. So there are many people who, when they start carbidopa-levodopa, are taking it at like 7, 12, and 5, or something of that nature. If there are nighttime symptoms to treat, or there is significant slowness, stiffness, or tremor in the morning, we'll offer a nighttime dose. But if we're just taking a nighttime dose just for kicks, there's no use of it. Overnight, you actually make dopamine in a little bit of a store. So you can actually make dopamine and keep it in those cell endings so that by morning time, you may actually feel your best. And some people rejuvenate overnight like that, and they don't need dopamine overnight. So they don't need levodopa overnight. And other people are the exact opposite. So it's totally an individual answer.
Awesome. And this question comes from Jody, and she asks, are there any interactions with like supplements, dietary supplements?
Jody, you've got it. Well, it depends on which medicine you've got. This is a good one. I like this one. So there's a nuance to carbidopa-levodopa metabolism, and we are, as the movement disorder community, telling most of our folks to start taking vitamin B12 and folate on a regular basis. And that's because we think metabolism of carbidopa-levodopa is a little bit more clean, so to speak. But in terms of over-the-counter supplements causing problems, I hate to say no, because I had written like St. John warts can cause a problem if you're on an MAOB, and there's definitely other things like that. So I would say a good strategy would be to bring your supplements to your doctor and have them look at them, because there's a lot of supplements that in excess, regardless of the Parkinson's thing, cause problems. I didn't answer it. Basically, I would do it on a case-by-case basis.
Fair enough. There's a lot out there, so it's hard to tell exactly which ones. Okay, so our next question comes from Mindy, and she asks, what non-pharmacologic therapies would you recommend for strong tremors? Weighted blankets, etc.
Okay. So I would actually piggyback off of a non-Parkinson's website. So there is a website for folks who have essential tremor, and it's called the ITEF, so the International Essential Tremor Foundation. And I think you just write essentialtremor.org. And people with essential tremor, they don't have Parkinson's typically, but they do have tremor, and they have an excellent portion of their website on adaptive techniques, so non-medication techniques to help with tremor. Just so you know, there's going to be medicines listed there that don't work in Parkinson's, but I'm just talking about the adaptive strategies. So sometimes there are weighted spoons. There's spoons with or different utensils that have a component that spins to help cancel tremors. There's different devices that people can kind of strap onto the hand to weight the hand down to help with tremor. So those are sort of non-pharmacologic options for treatment. Some people notice that when they're very mindful of their tremor, they can minimize it for a brief period of time. So what we do is we have them hold something in the opposite hand. So for example, if a person has a right hand tremor, they want to use that hand, we'll have them put a squeeze ball in the other hand. Really focus on that squeeze ball, try to multitask and do whatever they want to do in that opposite hand. Sometimes it works, but if there's a big tremor, it probably won't work. Those are kind of the things that come to mind. But yes, definitely going to that essentialtremor.org adaptive measure. It's either adaptive measures or adaptive techniques. There's some pretty good options there.
Awesome, and I can include that link in the follow-up email as well tomorrow for folks. And then it looks like we have another raised hand from Paulette. Paulette, I'm going to go ahead and unmute you, and you can ask your question directly. Maybe. You may have to unmute yourself if you are. Okay, we'll come back. We'll come back to you. We'll go ahead and try Lana. Lana, you have your hand raised, and we'll go ahead and unmute you, and you can ask your question directly.
Is that me?
Yeah, that is.
I didn't know my hand was raised, but in the meantime, since I had to be gone for the critical part of the best way to take carbidopa, levodopa, I had two different people give me two different sets of directions. But based on what your talk was, one said take it 3 times a day, watch the protein intake. The other one said take a half tablet as needed. So I got confused, and then I missed that critical part because something was happening here. Could you just review that, please?
Yeah, so it's basically an individual answer. There's this advice about what to do with carbidopa, levodopa is based on what symptoms are for you. So there's no one fits all kind of an answer. For example, if a person has tremor that responds to that carbidopa, levodopa pretty nicely, but the medicine only lasts every 2 hours, then they may be taking a higher dose on more frequent intervals. If we're treating symptoms that tend to respond for longer durations of time, then they can get away with fewer doses during the day. In the beginning of a person's relationship with their carbidopa, levodopa, it's much more forgiving, whether or not you eat protein, whether or not you actually take it on time. As a person has more years under their belt with Parkinson's, you have to be more strict about timing, and often you have to be more strict about protein consumption.
It's mostly timing related to symptoms. It was sort of, and that's pretty much what you just said.
Yeah.
Okay, thank you.
Yep.
Thank you. All right, so it doesn't look like we have any other questions about the presentation coming in. So let me go ahead and recap real quick. We will be having a third session on June 15th. It's a Tuesday from 4 to 6, and it's all on exercise and efficacy. So go ahead and be sure to keep your eye out for that if you'd like to attend. There's a survey that's going to come up after this presentation is over, so please take a moment to kind of fill that out for us and give us your feedback. And with that, I would like to say thank you, Dr. Solis-Cohen, so much for presenting today. It was, as always, so thorough and wonderful, and we really appreciate everything you do for our community. So with that, I'll say good night and farewell.
Thanks, Lena.
Yeah.